All right. Thank you so much for joining me this afternoon for another GHAPP MASLD MASH Community Network event. My name is Jordan Mayberry, and I am a physician assistant at UT Southwestern here in Dallas, Texas. And today we're going to be talking a little bit about MASLD pharmacotherapy. You can use this code here to register for the meeting. And then the second code here that I'm sharing is for our GHAPP MASLD MASH community network, which is a great space for us to view some disease state education and then also view the Madrigal Rezdiffra promotional program. All right, so let's talk a little bit about the current treatments that are available for metabolic syndrome. So, as we know, we want to target several different areas when we think about MASLD and MASH. Number one, it's important for us to think about weight loss. So, our first line treatment for weight loss is these lifestyle changes, diet and exercise. There are medications. We can also consider bariatric surgery for our patients that are morbidly obese and do not have decompensated cirrhosis or portal hypertension. And then some of the newer therapies that are available are the GLP-1 agonist and then our dual agonist. When we talk about treating type 2 diabetes, we want to not only treat type 2 diabetes, but try to decrease the cardiovascular risks. So we're thinking about treating hyperglycemia with our GLP-1s and our SGLT2 medications. We want to make sure that the hypertension is well controlled, and we're considering statins for their dyslipidemia. We'll talk significantly this afternoon about liver-directed treatments. Some of the older clinical studies show that vitamin E may be helpful, and we'll go into that in detail. We'll talk a little bit about pioglitazone, and then, of course, the newest medication on the block that is used for targeted MASH therapy is Resmetirom. So the GLP-1 receptor agonists are for after food digestion. This stimulates glucose-dependent insulin secretion. It suppresses glucagon and it delays gastric emptying. It also directly works on the hypothalamus to promote satiety and reduce energy intake. So patients will say that they just feel less hungry. GLP-1s are also used to lower blood glucose and can cause weight loss. So this is helpful in our type 2 diabetes and for weight loss. So how should we be using this in hepatology practice? Well, there has been some recent data that has been released that showed the comparison of semaglutide 2.4 milligrams weekly compared to placebo. And what the early data is showing is that there is significant improvement in liver fibrosis without worsening of MASH in the semaglutide arm. And we know that these GLP-1s can help with weight loss. So we should consider administering GLP-1s for our patients that are overweight and have a diagnosis of MASLD, as this may be helpful for decreasing fibrosis. One thing that we have to be aware of in our practices, as a lot of us treat both GI and hepatology patients, is that GLP-1s delay gastric emptying, which can increase the risk of aspiration on anesthesia. So if a patient is going to be having a procedure like an endoscopy or a colonoscopy, we want to make sure that patients do not take their dose 7 days before their scheduled procedure. Let's talk a little bit about vitamin E. The dosage that was studied on vitamin E is 800 international units a day. It's used for patients that have non-diabetic MASH without cirrhosis. So the PIVENS trial is a landmark study that showed that vitamin E actually improved liver histology specifically in non-diabetic patients with NAFLD. So about 43% of those patients showed histologic improvements. Now, the limitations with vitamin E, as you can imagine, in a patient population like MASLD, is not being able to use this medication in patients that are hypertensive or diabetic. And we know that those are two of the major risk factors for MASH. So that really limits how we can use vitamin E because we cannot use them in diabetic patients. So the 2023 AASLD guidelines suggest that vitamin E may improve MASH, while the 24 EASL guidelines do not recommend the use of vitamin E just because of its limited efficacy and its potential risk in our diabetic patients. What about pioglitazone? The dosage for pioglitazone is 30 to 45 milligrams per day. The indication is in MASH patients with or without type 2 diabetes. The PIVENS trial is also the trial that looked at the use of pioglitazone. And this particular trial showed that there was no benefit of pioglitazone over placebo for improvement in histology and MASH. However, there was improvement in secondary outcomes, specifically in improving cardiovascular risk. So this medication is not used for direct liver therapy, but may be helpful when we're talking about reducing cardiovascular risk in this patient population. Now, one of the limitations and considerations with pioglitazone is that there is potential weight gain. And with this patient population, we really want to focus on weight loss. So this may not be an ideal medication to use in our MASLD and MASH patients. Resmetirom is the first FDA-approved medication for the treatment of MASH. It is specifically to be used in patients that have MASH with stage 2 to 3 fibrosis. It's a thyroid hormone receptor beta agonist that selectively binds to the thyroid receptor hormone beta. So what we know about thyroid hormone receptor beta and its use and link between MASH and the liver is that low thyroid hormone receptor beta activity actually worsens mitochondrial dysfunction, increases lipotoxicity, and increases inflammation. So this thyroid hormone receptor beta agonist acts in multiple ways in the liver. It causes fatty acid oxidation. It also causes mitochondrial biogenesis, and it is a direct anti-inflammatory and anti-fibrotic effects within the liver. The pivotal trial for looking at resmetirom is called MASTRO-NASH trial, and it's an ongoing phase 3 randomized controlled trial. It looked at patients that had biopsy-proven stage F1B, F2, and F3 fibrosis. And the two primary endpoints for this particular clinical trial were resolution of MASH without worsening of fibrosis and improvement of fibrosis by at least one stage with no worsening of MASH. The most common side effects with resmetirom were diarrhea and nausea. Using this medication in clinical practice, I will say the diarrhea is very common. Most patients experience diarrhea. It typically happens early on in treatment and will improve within a week or two. So I think it's really important to educate patients about the possible side effects so we can continue them on medications, knowing that it will get better if we just continue meds. And we can use things like Imodium to help for symptom relief. So what were the outcomes of this particular clinical trial? When we talk about the primary endpoints, about a third of patients saw MASH resolution with no worsening of fibrosis, and about a third of patients saw improvement in fibrosis by at least one stage with no worsening of MASH. How should we be using this in our clinical practice? So the ideal patients for the use of resmetirom are adults with non-cirrhotic MASH, patients that have at-risk MASH. The definition of at-risk MASH is stage 2 to 3 fibrosis, and this should be used in conjunction with healthy lifestyle changes like diet and exercise. So here we just see some of the possible drug-to-drug interactions with resmetirom. I think probably the most significant that we are going to run into in our particular clinical practice is the use of statins in resmetirom. So it's really important that we understand the dosage of the statin that the patient is on and which statin they are on, and making sure that we're making those dose adjustments if we plan to start patients on resmetirom. One thing that often comes up whenever we are talking about new treatments with patients is, well, how long am I going to have to be on this medication? And how often am I going to have to see you? Well, there are currently ongoing treatments for MASH, for Maestro-NASH, and so we will have some more data about long-term therapy. We likely need restaging or fibrosis while these patients are on treatment. So I would recommend that we bring these patients in at a year of being on the medication to reassess their fibrosis stage to determine how they are responding to the medication. And then, of course, experts are currently working on some cutoffs and how often we should be testing patients on the medication to determine the duration of medication. With a new medication, there are still questions that remain. One of them is we know insurance will have a large role to play in this. So widespread use will depend on insurance coverage. We will have to make sure that we are staging patients periodically while on therapy and make sure that we are monitoring lab tests. We need some more recommendations on treatment duration and then when we should be discontinuing treatment. So safety signals, if we're not seeing improvement in liver enzymes, if we're not seeing improvement in the fibrosis score, should we be considering discontinuing the resmetirom? And there should be more guidance on that coming. And then the landscape is changing very quickly. There are multiple agents that are currently in clinical trials and there will likely be newer and more options available in the near future. So it's a very exciting time for the treatment of MASH. We know that this is a multi-organ disease state, and so we do need to consider using medications to treat type 2 diabetes, to treat hyperlipidemia, to treat weight loss. But resmetirom, of course, is a great therapy to add for liver-directed treatment in our patient population. So thank you so much for joining me this afternoon. And if there's any questions, I'd be happy to answer them.